Did you know that despite the well-recognized benefits, pulmonary rehab is available to fewer than 4% of Americans living with COPD? Let's put it another way. People who receive pulmonary rehab are healthier. They feel better. They go to the hospital less often. They have fewer exacerbations, and they have a better quality of life. Telehealth and home-based pulmonary rehab are also beneficial. In the last 30 years, there has been an increase in research exploring alternatives to clinic-based pulmonary rehab. Despite these benefits, many people are unable to participate in pulmonary rehab because of travel requirements, few number of clinics in their communities, and in fact, some people don't even know pulmonary rehab exists. In addition to these barriers, today we have a new challenge. Coronavirus changed everything. Take a deep breath. Help is on the way. To address these challenges, we developed Health in Motion. Health in Motion contains an assortment of tools to help your clients manage their health, from individualized exercise programs to personalized COPD action plans and standardized assessments, all from your client's home computer, laptop, tablet, or phone. Health in Motion is a versatile software platform. It can be used as an adjunct to or upon discharge from clinic-based pulmonary rehab or from home. It even works with individual telehealth visits, as well as offers content for group telehealth, exercise, and education classes. Let's talk about how it works. The clinician creates the home program, the client completes the program, and then the clinician reviews and updates the program. The home program can consist of standardized tests, individualized exercises, lessons, and a personalized action plan. Let's get into the details. Step 1. Create the home program. Use the simple drag and drop interface to select the exercises, then adjust the parameters for a personalized program. Next, create the home program schedule. Simply select the program and choose the days you want your client to complete the program. And finally, assign the exercise program to your client's account. You can also use this same process to create, schedule, and assign tests, action plans, and lessons. Step 2. After your client downloads the app to their computer or phone, they are then ready to complete their personalized home program. Each day, your client will log in and receive their daily task list. Their task list can be comprised of an action plan, a daily survey of their lung symptoms, it contains personalized actions recommended by their physician. They can use the COPD calendar to see how their symptoms have changed over time. The daily task list also offers action plan reminders that they can check off when completed. Personalized exercise routines can include breathing exercises, arm and leg strengthening and balance exercises, and aerobic exercises. Clients use the simple interface to add details about their exercises. Their home program can also consist of lessons which contain interactive elements, multiple choice knowledge check-ins, and quizzes to test learning. And finally, you can assign standardized assessments for them to complete on regularly scheduled intervals to measure changes in their function. Next, the data is captured and sent back to the web app. All data is captured in a standardized format, which will inform changes to your care plan and make documentation easier. With the care plan updated, you simply assign the new plan to your client's account and they'll receive it the next time they log in. In addition, you can combine your client data to create population health reports, compare different locations, and even use the outcomes as a marketing tool. Health in Motion brings value to a number of users. including the person with COPD, the provider, and even the insurance company. Health in Motion can be empowering and even help people recognize when their lung health is changing and offers them actions to help avoid an exacerbation. And when the weather gets bad, they can follow their pulmonary rehab program conveniently from home. Using instantaneous client data, clinicians make more informed decisions. Since Health in Motion offers communication between you and your patients, they are likely to have fewer exacerbations and readmissions. Health insurance companies also benefit because they provide more personalized services and have healthier, better educated members. And when members are healthier, everyone wins. Let's take a look at a financial model. It's no secret that COPD is expensive in terms of healthcare costs, caregiving, and lost days of work. We also know that the prevalence of COPD is higher in rural communities. The good news is that pulmonary rehab offers an incredible cost savings, and because people go to the emergency room less often and have fewer exacerbations, the overall cost savings can exceed $4,000 per patient. In addition, there's also revenue-generating opportunities for healthcare systems offering pulmonary rehab. While telehealth e-visits and remote monitoring reimbursement is a moving target today, chronic care management services can be provided by physicians, including those at rural health clinics and federally qualified health centers. Health in Motion is just one more tool for a physician's toolbox to support remote surveillance for disease management. Due to coronavirus, CMS is evaluating changes to their telehealth requirements. Stay tuned for updates. Health in Motion was developed with an extraordinary team of scientists, clinicians, software developers, designers, and artists, as well as university and industry collaborators from all across the country. Health in Motion was funded in part by the National Heart, Lung, and Blood Institute of the National Institutes of Health. It's being launched now in conjunction with our multi-site clinical trial. Please contact Dr. Cheryl Flynn or Chris Ashford for more information. Thank you for showing that. I got bumped out, so I'm glad to know everything was still progressing nicely. Can you all hear me okay? Oh, yeah. Okay. Okay. Yeah, so just do you guys have any questions? Do you want me to clarify anything? You want me to go to any details?
Oh, let's see, Grayson. We couldn't hear you. Try again. Let's see.
That's why I'm using my phone. But in any event, Cheryl, you left the headline out. Cheryl has offered the Grayson Pulmonary Rehab Clinics the opportunity to use this program at no cost during the coronavirus, and then, of course, to see if you wish to continue with it.
That's really wonderful and very generous. Everybody, if you have any questions, comments, I know we have a couple of chats. I hope you see that people think it looks amazing, but you're welcome to unmute yourself and speak, you guys.
Well, maybe this is Brandy Bell. Sherry, this is an awesome program, and thank you for offering it to the Grayson Dorney sites for free during this COVID-19. A question I do have is, if this were something we ended up going with as a form of telehealth, do my patients have to download a program, or are they just going to go on the internet and type in the website and just kind of log in from there?
Yes, so it is an app that gets downloaded to either their phone, their tablet, or their laptop or computer. It is available in the App Store to download. And you can also, for like Windows and Android, you can just download it directly from our website. But the app side is downloaded. The clinician side is a web app. So the clinician logs into a website and assigns and creates those programs, as I mentioned. But on the patient side, it is an app.
Thank you. I have another question. Do you have a larger tutorial that shows how you create those assignments and things?
Sure.
Like training course? Okay, awesome. Thank you.
Yes, if you all decide to go ahead and use this, we would go through a full training with you. So this was just a quick introduction so you could see how it works and what it looks like.
That is great. Thank you.
I see a question from Heather asking, is there a possibility for cardiac rehab in the same manner? The possibility is yes, but we haven't developed it yet. I think there's a lot of similarities. You certainly could use many aspects in its current form, but we don't specifically have, for example, lessons that are specific to cardiac rehab. All of the education modules are specific to following like a general pulmonary rehab type education program.
This is Sam Giordano. I wanted to ask a couple of questions. First of all, is this being used now?
No. We had just gotten approval to start our clinical trial right when coronavirus hit. And so NIH has put us on a temporary hold until after coronavirus because they don't want us to recruit subjects and have people come out of their home in the midst of all of this, especially people with COPD. So it's temporarily on hold.
Okay, well that answered my second question, which was, were you tracking the data and going to publish it? Because people buy results, as you know. I think it's a very impressive program. And I would think, as I watched the video, I was thinking, okay, well, are you targeting payers? Because I think in many respects, they could drive utilization and usage. Because part of the reason we don't have as much access to pulmonary rehabilitation as we'd like is we don't have enough demand for it, especially in terms of referrals from primary care physicians. And of course, some of that is driven by a lack of awareness, but the other part is that many primary care physicians, especially in rural areas, know, there's no sense in referring somebody to a program that doesn't exist in their area. So this would certainly work as part of what we need in our landscape right now in our healthcare system. So it's very impressive. Congratulations.
Well, thank you. Thank you. I love hearing all these positive words. We've worked really, really hard on trying to get this right. We've been in collaboration with Atrium Health and also Trina Lindbergh's been fantastic out of UCSD. And I wanted to address the payer comment, and we definitely will be approaching payers to when we have data. So they like to know that there's been some successes, and as soon as we have that, we will be approaching them. I'll throw the caveat out there, unless you know somebody who would be really receptive right now to seeing it, by all means, I'm happy to talk to anybody. But I know from experience in the past that they prefer to see some data first.
Absolutely. Thank you again so much, Cheryl. This is super interesting, and everybody is really glad you could join us. And I'm sorry it's so early there.
No problem. Thank you all very much for the invitation and the opportunity to present this to you. And I look forward to hearing from you all soon. Yeah, let me know what you think.
Yeah, definitely. If we have any follow-up questions and stuff, is it okay if I email you?
Absolutely. Yeah, follow up, or if somebody wants a more thorough demo, like a live demo where I could kind of click around and show people different things, happy to do that. It'd be great if it wasn't at 5 a.m. because I'm not my best right at this moment, but that's okay. Yeah, anything you all need from me, I'm here for you.
Thank you. I think we had a couple more comments real quick.
Okay.
Dr. Doyle, we'll start with you. Dr. Doyle, I apologize. We're having trouble hearing you. Grayson, did you want to say something while we figure that out?
Well, I did. I wanted to thank Cheryl for getting up so early and for sharing this with us, because it is provocative. And as you know, there's not a lot out there that we can use with patients when we don't have the face-to-face sessions. And this is certainly an alternative. And it is the wave of the future. There's no question of that. And Cheryl, you do not have to wait for the rest of the hour. You can go back to bed now if you want. But we'll wait and see if Dr. Doyle is able to connect.
Okay. Can you hear me?
We can hear you better.
Okay. Hi, Cheryl. Thank you for that. I'm a family doctor here in West Virginia Community Health Center where we do pulmonary rehab. And I actually work with different pulmonary rehab teams, all the GAD-PRC teams. And this is really, really interesting. Thank you. Sounds like you're in San Diego, or where are you?
I'm in Los Angeles.
Los Angeles, okay. So how can I talk to you more about this?
Let's set up a meeting. I'm happy to talk to you.
Okay.
Should I put my email address in the chat in case people want to contact me? Would that be okay?
That's perfectly fine. I can send it out in the recap as well.
Okay.
Is there a website we can go to look at a little more?
Yeah, yes. I'll put the website there also. My company is called Blue Marble Health, website bluemarblehealthco.com.
Say that again.
It's in the chat if you can't hear me clearly. I don't know if
Okay.
I'm, but it's Cheryl. I'm sorry, the website is bluemarblehealthco.com. Email Cheryl at bluemarblehealthco.
bluemarblehealthco.com. And actually, who's our friend Grayson at UCLA who works, I forget his name, who's here in Los Angeles. Who's that?
Are you thinking of Rick Cassaberry?
No. At the Rehabilitation Research Center at UCLA. He's one of the people who worked with Dr. May on the Propel, who've been trying to do that Propel study.
You're breaking up a little bit on my end, but it sounds like you're talking about a doctor at UCLA,
Yeah.
pulmonologist.
Yeah. Is it Tony? Anyway, do you work with them at all on this?
No, I haven't. We've worked with Keith Robinson in Florida and Atrium Health and Trina Lindbergh. Those were our main collaborators for getting the content, some of the design, the which topics to cover for the classes, and then the exercises and the COPD action plan. That feature was designed to a large extent with how Dr. Howard does things at Atrium Health.
Okay. And what is Atrium Health? Where are they?
Atrium they're a large healthcare system in North Carolina, South Carolina. I'm not sure exactly how broad their reach is, but I know it's in that area of the country.
Okay. How about any role so far of AACVPR?
Any rule?
Role.
Oh.
Any role by AACVPR?
Oh, any role by AAC. So, Trina Lindbergh is on the board.
Okay.
And she was a huge consultant, and we used her knowledge tremendously in the development of this. And then I did present some early results from some usability testing at AACVPR, not last year, but the year before, I think it was.
And Sam Giordano asked a question that I didn't think of, a good one, whether you have started, and you said no, we're on hold. How does that relate offer to GAD-PRC?
I'm not sure that I caught the question. I'm sorry.
Go ahead, Caitlin.
I think Dr. Doyle is asking, since you haven't been able to start, how the Grayson Dorney Koppel pulmonary rehabs here are able to offer it.
Oh, you would be offering it more of just like a straight, it's not through the clinical trial. You would be using it because you're doing things like telemedicine and having alternative, strategies for getting, with a clinical trial, there's so many requirements and strict things that have to be met. And one of them is that people were coming into Atrium Health to get evaluated, and then they would be taught how to use the platform, and then they would take it home. So it wasn't set up as a straight telehealth, setup, just because it's our, first time taking it out into the real world. And so we had to make sure we had some extra measures in there to get it past. Actually, it was just the way we set up the study.
So we can go ahead and use it now.
Yes, I mean, if you think of it as another tool in your toolbox, it's, once you take a look at the education modules, you would make a decision about which ones you think would be appropriate for your patient. The COPD action plan would be similar to a COPD action plan that you might do on paper. The same kinds of symptoms are there, and then you could make them very personalized for your patients about what to do if this or that happens, if their symptoms worsen. In terms of exercise, it would just be, it's just a guided exercise with some breathing reminders. So, you would assign, or the respiratory therapist would assign the exercises that they wanted their patient to do. And then as far as the tests are concerned, a lot of them are, the standard, like the CAT or the MMRC, things like that, which, we don't necessarily need everybody to do all the time. Some of them are more of screening tools than like regularly scheduled. But there's also some functional tests. The 6-minute walk test is actually in there. It's a little bit cumbersome for a person to do on their own, just because it asks for so much data to be inputted. But it could be done. There's also the timed up and go, or the 30-second sit to stand would be another good one that you could have a patient do remotely to get a sense of their endurance and functional ability. And one thing wasn't in the video, but just so you all know, you can connect a heart rate monitor to it and see the data related to heart rate. We don't have a Bluetooth pulse oximeter built into the system just yet. And the main reason for that is because people don't tend to have a Bluetooth pulse oximeter at home. So we started to go down that rabbit hole, but did a lot of user testing and, kind of market research. Everybody told us, I have the $25 pulse oximeter at home, and that's what I use. And so there is an education piece. It's not intended to just be like download the app and off you go. You want to make sure that you're, tracking your patient, educating them how to use it, and between the two of you and the app, it makes a stronger communication when people are remote from you.
How's my audio with you right now, Caitlin?
It's good.
I feel like I'm yelling.
We can hear you. It comes in and out a little bit, but we can normally piece it together.
Okay, how about you, Cheryl?
Yes, I can hear you.
Okay. I definitely think that we can do this and we will do this. The question is scale. And two of the challenges that we face, and we actually have gotten a whole lot of data in the last 3 weeks about this, is how many of our Medicare patients have the video conferencing capacity in their residence. And we're finding about 20% of our telemedicine visits are done video. We have a strong incentive to do that because we know Medicare will pay for that. And about 80% are being done telephone only. That will be an issue. And then the financial, I'm really interested in your, I've got about 4 or 5 financial model slides. And I'm really, really interested in digging more into that. See what that's going to look like after COVID, well, mainly after, when it's really implemented.
Sure.
Grayson can and will speak for herself, but her passion has been pulmonary rehab and access to care for people who are living in rural areas. And that's us. And so trying to get this out to people It's a big challenge. We know we can do it with some of our patients, and the question will be how many. I think there are many of our patients who aren't getting pulmonary rehab, if they had the video capacity, would get it with this tool.
So yes, that's the technology is a challenge. That is certainly a barrier, and you know, until we have like broader infrastructure with broadband and whatnot across our country, I think it'll probably still be there, especially in rural areas. That being said, it does work on a person's phone. So you can download the app and then maybe get on a phone call and kind of walk the person through if they don't have a video, if they can't do the video chat because of their streaming services. And the other thought was, yeah, I think we can definitely have a longer conversation around potential reimbursement models to essentially make it be a no-cost type of offering. So, you know, if whatever expense is being spent on the application is more than recoverable from some telehealth reimbursements, and that's even using codes that were present before coronavirus by physicians. I know respiratory therapists are not on that list of non-physician professionals who can get reimbursed for doing telehealth. You know, hopefully that will change. But in the meantime, physicians, there are codes that physicians can use, and they were there before coronavirus. So I think those are a fair game for getting reimbursed for some of the costs associated with this.
In your straight Medicare model, in other words, fee-for-service Medicare, how do you get reimbursed? How does Health in Motion get reimbursed? And one thing you should know is that just small co-insurance, but sometimes called co-payment, is an obstacle for many of our patients to do pulmonary rehab. As incredible as that may seem, that $20 or so each time is an obstacle for many of our patients. But putting that aside, what's your model to get reimbursed?
Right. So, you know, it's a little bit hard for me to say exactly because every state is so different. So I'd have to do a little bit of research to try to figure out what could work where you are. But our business model is a simple SaaS model. So there's a monthly fee to the clinic, and then it becomes free to the patient essentially because the clinic pays for it. So there wouldn't be an outlay by the patient unless they had to maybe buy a phone or, you know, piece of hardware. We do have the Health in Motion is able to work on a very inexpensive tablet like an Amazon Fire, $99 Fire tablet. So even if people didn't have a device, as long as they could gain access to Wi-Fi, which could be potentially at a local library or, you know, someplace, they could take an inexpensive tablet and you know, get some benefit from it. But I think these are great questions and ones that I would love to sort out with you because I don't have all the answers. And I think, let me put it this way. I'm willing to work with whatever system you guys have in place that would make it work for you guys. I really understand that there's limitations and you know, I just want to make it plausible. So maybe we can brainstorm together and look at some codes and things that, you know, you can let me know if it's a code that could be used in your state and by whom and that sort of thing.
Thank you.
You're welcome. I'm just going to write down this one email real quick, and then I'm going to, well, any other questions, I'm happy to take them. I just wanted to make sure before I got off. Were there any other thoughts or questions?
This is Dr. Sheila. I just wanted to say that I think this program looks great and really promising. You know, we all, at least in this group, most of us are in rural settings anyways, with our patients having to travel. But even then, I've got patients that still can't swing twice a week. They don't have transportation. They don't have somebody, you know, to take them or a car themselves. And so I think this program definitely has some some applications beyond just the coronavirus pandemic for some of my patients. So I think it looks really great. And I especially wanted to tell you that I loved that the treadmill was facing out over this beautiful scenic area. I think that was gorgeous. So.
Oh, thank you. We definitely tried to throw in a few little surprises in there. Those backgrounds actually change and they're random. So when a person logs in, they don't really know what they're going to see for the day. But yeah, so I appreciate that. And I think you're absolutely right about even lengthening, you know, we have those limited number of visits for a lifetime. So if there's a way to potentially even spread those out a little bit longer, or only use you know, fewer of them, and then have a person be able to come back and use more later, I think that, you know, all of those are, I think, of great benefit to the patient. So. You guys have a lot of time. I know you've got a busy, packed meeting. You mentioned that at the top. So thank you all very much. And I'm happy to jump on another call or do another demo, or just let me know what you all need from me.
Perfect. Thank you so much again. We're so appreciative that you were able to be here with us.
Thank you. And thank you, Grayson. I really appreciate the opportunity.
All right. Grayson, are you ready if I share the screen for this part?
Yes, yes, I am. I do want to preface these remarks, though, by saying that you realize that I am not endorsing anything. However, I thought this was a developed program that would be of interest to you to see what is out there, because eventually in rural, we're going to have to be able to handle a lot more people with lung disease than we can handle face to face. Now, I did prepare slides. The first 6 slides, I guess, I actually sent to you as a document. And this was prepared by could you go to the next slide, please? This was prepared by the ATS, and I was part of this working group, and it was chaired by Chris Garvey. So our normal working group dealt with improving reimbursement for pulmonary rehab. However, we quickly, in early March, had to shift to what's out there and what's available as a resource. We can skip through. I want you to have these slides permanently, though, because they do list resources. But I'd like to go to the last slide. And this is new. This information was prepared for the AACVPR, and it's courtesy of them and of Chris Garvey. And I do think you should take a look at what Chris is doing on the YouTube link that's there. Look at the Australian model, the Canadian model, and the British Thoracic Society model. Now, for patients, and it's hard to find programs for them, we have both the lift class and the sit and stand to use as a temporary measure. And I think it's important that for those patients who do have connectivity, that you point them in this direction. And it may be that those who are in the existing classes that have been suspended would be able to easily check. I know you check by phone with them at least weekly, since I've been on the various West Virginia COVID calls and the other calls. But it would be good to point them to use one of these programs if available. So I told Caitlin and Dr. Sheila that I would be very brief, but I do want you to be aware that there are resources out there, and you could be using them now. So I'd be happy to answer any questions, and if not, our time is shrinking. I know Dr. Sheila wants to go to some COVID issues.
Perfect. Thank you, Grayson. Do you guys have any questions, comments? Again, you're welcome to wave at me and I'll unmute you, or you can unmute yourself.
Grayson, this is Brandy Bell. I have reached out to several of our active patients, and there's a good handful, probably 5 out of the 8, that are actually watching the TV program Sit and Be Fit that you've mentioned as a resource, and they're doing really well with it because everything is from a chair that they can do in their living room. So that is a good resource for these patients.
And you don't have to worry about them getting hurt when they're sitting down. That's good.
Yes, and they're not having to log on to a computer or navigate through an app, because this one is just turn the TV on. So this one they can't really argue with me about, well, I can't handle that. They know how to turn the TV on.
Yeah.
Luann?
I just want to say thank you for those resources, Sam. We had looked up some and had reached out to you, and I'm still going to review more on the website that you had referred me to go to. These will be good as well, because some of our patients are very computer savvy, some aren't. So knowing that they can have an option of TV versus some of the others will be good.
Awesome. Thank you, Grayson. I think that's great, and definitely we'll send those out with all the recap info. Any other questions, comments? All right, guys, so we can move on to, it's basically a question and answer, but do you guys have any COVID-related questions or anything about sustaining your not in-person programs or anything like that going on? I know several people here were on a call on Friday that was very, very great, and you were able to share and talk, so we have time. Dr. Doyle, let's see, wanted me to remind people about how to copy and save the chat. It's pretty simple. When you chat into that chat box, there is a box that says to, and it'll say everyone, or you can select somebody privately. Across from that, there's a little ellipses box. You can click that and you can save the chat. Sometimes it's good if somebody's posted their email or a web page or something the way Cheryl did. So it's nice to be able to save that and go back to it. Excuse me, Dr. Sheila, how are you doing?
I'm doing well. I'm working from home and trying to manage the ICU from a distance. But I'm here to answer any questions that anybody has. If there's any burning issues or questions or anything at all. I didn't really have much to put together. I know if you're like me, you're being somewhat inundated by all of the COVID. You're getting lots of Zoom meetings and phone calls, and so I don't know if there's much new to talk about, but I'm here to answer any questions.
Thank you, perfect. And I do know there's a lot of COVID stuff going on, and it's taking over our lives. There was a question in the chat. Let's see, what does testing look like? Wait, what does testing of all NH residents and employees look like in your
nursing home?
Oh, thank you. I was like, huh.
Yeah, the governor just put out an order that all nursing home patients and employees should be tested. I think because there's been so many different outbreaks. There was one here in Mon County. There was one down in Kanawha County, and I think Wayne County had one. And so I think that's where we're seeing these pockets, is a lot of them are nursing homes. So I think it's interesting. I think it's going to be a difficult task because it is so large, and so many areas are still, I think, limited on how many tests they have and how fast those tests can be run. But I definitely think it's a worthwhile undertaking if we can do it.
I think the FDA is looking at approving 3 new tests that'll go along with the one they have approved, hopefully for a rapid IgG, IgM. So hopefully that'll help soon.
You know, my concern is somewhat of the practical side of this is that, you know, we're seeing these patients that are so likely to have COVID. They've got all of the symptoms, you know, their oxygen saturation is low, they're requiring the ICU and ventilation, and they're still having negative tests. And so I think one of the things that we're seeing in this pandemic is that they've pushed to get all these tests available so that we can do this testing, but we still have questions as to how reliable these tests are, you know, and just because they have a negative test, can you really rule them out? And that, you know, goes along with, you know, then we're still spreading stuff. If somebody thinks they have a negative test and they're going out to the store or going to visit family or, you know, all this other stuff, you know, they're still a carrier and they're still spreading the disease. So it's even if we are testing them and they are negative, is it a true negative?
I definitely agree. And I think they found out that it was one of the tests. I can't recall if it was a spit test or a blood test, but one of them was definitely giving inaccurate results. Anybody else? There's 11, let's see, in Fayette County, 1,100 tests have been given. And I think in PA, we have seen a few asymptomatic positives in our testing for nursing home patients, yeah. We have about 10 minutes. Oh, testing all of the nursing home will require 1,100 tests, I see. Any other questions, comments, or contribution to the discussion? I wanted to let everybody know, I think we are going to revert back to our planned sessions from here on out. I'll reach out to the people who are scheduled afterward, but just to try to keep some information flow going, and we'll always leave a moment at the end for questions or comments or updates if anything big is coming out. But it seems like a little cumbersome to keep trying to change, and then we're losing out on the information that we have planned and stuff. So we'll talk more about that soon. We did have a comment. I just recently found out places were doing throat swabs. Is there any information on this?
My understanding with some of the earlier testing was that it needed to be either a nasopharyngeal or an oropharyngeal swab. So if it's an oropharyngeal swab, you know, as long as they're getting back far enough, I would think that it would be okay. But again, you know, you've got to make sure that you're swabbing in the right area. If you're not getting back far enough because of a gag reflex, I would think that you're probably more likely to get a false negative. So what that means is that your result would be negative and the patient may still have the disease. So I think nasopharyngeal is probably still better if you can do it. At least that's my 2 cents.
Definitely agree. And we had a comment that kind of goes along with what we were talking about let's see, 4 patients at CAMC that were being treated for COVID, even though they were negative, treating 4 positive and 4 negative the same way. So there seems to be a lot of negative tests for some reasons, and possibly from poor testing. And I think that has been a lot of the issue. Dr. Sheila, do you?
Yeah, I agree. You know, my husband's on service right now in the ICU, and he's got 1 patient that has had a negative test, 5 negative tests. And they are so convinced that this patient has it that they're treating him like he does. And so, you know, I think, you know, that goes back to these poor tests, or maybe just not collecting from the right area. Although, you know, once these patients unfortunately decompensate and they're put on the ventilator, it's much easier to get a sample that's going to be a good sample. So if you have a good sample, which is something that's coming, you know, like a tracheal aspirate, or if they bronch these patients, there's very, very little concern that these would be poor specimens. It's more likely that it would be a poor test.
Absolutely. So I'm gonna make my always call for cases. You know, of course, we love having cases and having something to discuss. Dr. Doyle posted right along with that the first site to report a case of pulmonary rehab patients doing the health in motion at home should present as a chronic lung disease case, which I would absolutely love. I'm happy to help. You guys can email me or Mitra, and you're welcome to submit on the online case form. And we have about 5 minutes left. Any other comments, questions? Dr. Sheila, we super appreciate you answering the questions, and Grayson, thank you again for speaking today. Anybody else? All right, guys. So I think we're back on the 4th, May 4th. I think I have Dr. Doyle on the schedule, but we can chat about that. No worries. And you guys will all get the emails and everything. Everybody have a great day.
Thank you.
Thank you.
Thank you guys. Be careful.